TAVR has come a long way since the first procedure more than 20 years ago. Back then, the immediate or long-term effects of the procedure weren't well understood, so it was only an option for patients who didn't qualify for open-heart surgery. But today, that's not the case at all. TAVR is now a well-established procedure, and it's the treatment option that patients prefer most in my practice. The engineering of the valve's frame, leaflet, and delivery system have shown continuous improvements in the early days, and years of physician experience using the device have no doubt improved both procedural planning and performance. With these advances, TAVR is a minimally invasive procedure that we can expect most patients to go home from the next day. And the safety of TAVR is supported by strong data collected from thousands of patients over more than a decade. My own first-hand experience is consistent with that data. The majority of my patients tolerate the procedure well and are free from stroke or vascular complications. Additionally, as we monitor their recovery in the first year after the procedure, we see very few patients with significant paravalvular leak or bleeding events. There is also promising data on TAVR's durability as we treat younger and healthier patients. TAVR has shown durability comparable to surgical tissue valves in the same population over the last 5 years. These valves often use the same materials and processes as surgical valves. In fact, TAVR's largest durability analysis, studying over 200,000 Medicare patients, showed that within 10 years after a TAVR implantation, the risk of reintervention is low, under 2%. With this data in mind, combined with current guidelines and my own personal experience, I feel very comfortable offering the procedure to most of my patients over 65. And I'm also thinking about future interventions patients might need. With thoughtful planning of the index procedure, including valve choice and implantation technique, I may have an easier time gaining access to the coronaries for a PCI down the line if needed. This may also give us the option for a future valve intervention, including a second transcatheter valve. Today, patients referred to a heart team are evaluated for both TAVR and SAVR. The right choice is TAVR for many of those cases. Together, we team up with the patient and their referring physician to determine the right procedure, valve choice, and time of intervention to ensure that what we're doing is best for the patient now and into the future.